Hi, I'm Dr. Mark Kerner with the Spine Center of Hampton Roads, part of the Secours Medical Group. I'm here to talk to you about our center and our offerings for treatment of back pain and to answer any questions you may have about treatment of back pain syndromes. Here at the Spine Center, we see a number of patients who have complaints of neck, thoracic, and low back pain. That's basically pain any place from your neck, your mid-chest area, or your low back that can give you problems in your work or your recreational activities that slows people down or gives them a problem. We have a team of doctors here, both surgeons, myself, or non-operative physicians that are called physiatrists. Those are rehabilitation medicine specialists who provide care to evaluate your problems and to try to come up with a solution to get you back going so you don't have to spend your time visiting doctors. Our goal is to keep you away from me, from a surgeon, and try to get you better with non-operative treatments and to get you back doing the things you like to do. Back pain is the number one cause of days missed from work and aggravation. It's a huge cost to society today. You can't turn on the television without seeing a commercial from some company or another, either selling you a back brace or telling you that they're going to cure you with the miracle of a laser. There's lots of hokum being sold out there. Patients come in all the time asking for treatments and asking for different things. It's almost funny. It's actually quite sad. Lots of misinformation about the treatment of back problems. And so we pride ourselves in trying to give our patients a lot of information about their problems, try to treat them with, quite honestly, with honesty and truthfulness, and explain to them what we know and don't know about their back problems, try to explain to them what's been shown to work and what's not been shown to work. We give them what's been scientifically proven to give results and offer them the various choices that are out there and let them choose and make an educated decision about what type of treatments they would like and then go from there. Many of our patients are referred by their primary care doctors, their family doctors, or friends and family who have been treated by us in the past. Some of them just come off the street and call us directly for appointments, and we see both. Generally, patients don't come to see me initially. I'm a surgeon. Most patients don't need surgery. Actually, very few patients should need surgery. Most back problems get better on their own. Patients who generally need surgery are patients who've had neurologic issues or having progressive weakness or numbness or having an infection or having fever or chills, weight loss, or other dramatic problems in their spine, and that's pretty unusual. Most patients have pain. They wake up, they have pain, and most pain problems get better on their own with a combination of medications, things like physical therapy, exercise treatments. And we get patients better all the time. 80% of patients get better from their complaints in 6 to 12 weeks with what we call conservative care, non-operative treatments, therapy, exercise, use of appropriate medications, most of them over-the-counter medications. We try to limit the use of narcotics and other, in essence, dangerous medications when possible. We try to talk to people about how they got hurt and try to avoid getting hurt again. Talk a lot about lifestyle changes. Often that means things like exercise and weight loss, about how they do their jobs and how their workplace is set up. We talk about changing their desks and how they use their computers at home and other simple things that just allow us to avoid getting hurt so you don't have to go to the doctor or have to go back to the doctor. It's simple things like that that can make big differences in your life. Sadly, in some cases, people have problems that require greater interventions, and we use all the most modern technologies, MRIs and CAT scans and myelograms and nerve conduction studies and stuff like that to try to diagnose people and find out what's anatomically wrong with you. There are basically two different types of problems in people's spines that cause them pain that may require surgery or a surgeon to be involved in it. There are sometimes things that cause a pinching of a nerve compression, sometimes it's called spinal stenosis. And if it pinches a nerve, we call that a radiculopathy, or something that pinches a nerve, causes a pain that radiates down an arm or a leg. That's treated by unpinching a nerve. That's one type of surgery that unpinches a nerve. Another problem that people have is something we call instability. That's where the bones are worn away or somehow injured, where they're not tied together appropriately, and there's inappropriate motion of the spine that often causes pain in the middle of the spine, either in the middle of the neck or the middle of the low back. It can have a lengthy name like spondylolisthesis, which is a long word that just means instability, but it causes back pain, and different type of radiographic studies show that. Sometimes those things could be treated also by exercise and therapy, but sometimes it takes surgery to stabilize the spine and things we call fusions, where we get bones to heal together. And in those rare cases, then yes, I get involved, and we use the most modern technologies, whether it's disc arthroplasties, where we can do disc replacements to broken discs in the neck to restore normal motion, take pressure off of nerves, or fusions where we get bones to heal together so they're stable and no longer cause pain. And we do all these treatments through the smallest possible surgeries. Sometimes they are small surgeries where you can have a cut that's only an inch or so long and take people's pain away. Sometimes there's surgeries that take cuts that are longer. Often people see television shows or commercials where they have a Band-Aid covering up someone's surgery, and the goal of their surgery is to have a Band-Aid on it. Quite honestly, most surgeons laugh at those types of things because I specialize in taking care of people who had surgeries that didn't work, and they get sent to me, and they're hurting, and none of them really care about how big their scar was. They just care about whether or not they had pain and whether their pain went away. I never had a patient who did well who really cared how big their scar was, or I had a patient who saw a patient who did poorly but was happy that they had a small scar. People just want to feel better. So I talk about surgery not so much as minimally invasive surgery, which is a buzzword out there. We try to use the smallest surgery possible to get somebody well, which means I always try to use the smallest possible cut to get the job done. And so for some surgeries, that's a cut that's less than an inch long, and we get people home as quickly as possible and cause the least amount of pain. For other types of surgeries that are more extensive, I have to do very extensive cuts that are very long, but I only do them if that's what's needed to make someone feel better, if that's the size incision that we need to do to get somebody out of their pain or fix their deformity and make it hopefully so they don't need a second surgery and they don't have to come back and see me again. What patients want in general is to have the surgery that they have to fix the problem that they came in with. They'd like it to be the last surgery that they need, or at least the last surgery that they need to fix the problem that they have. Patients often come into me and they say, I just want you to fix it, doctor, so I don't have to come back here and get another surgery. I always hear that people with back surgeries have one and then they get another and they get another. And sometimes that is true. People have medical problems, and often people get other medical problems. And that's true with back surgery. I often tell my patients that when when your car breaks down, you don't generally go to the mechanic and you can't say to them, I want you to fix this flat tire so I never get another flat tire. It just doesn't work that way. We can fix you so that you get better, and we try to fix you in such a way that that problem hopefully doesn't happen again. But if I fix you well enough, I am trying to fix you well enough that you can get out and do all the things that you were doing before and have a normal quality of life. And part of that quality of life is to be active. And if you're active enough and do things, that means that you may hurt yourself again. You may wear something else out. You're going to be up and around. If I only fix you well enough to lay on the couch all day long, you may not break anything else, but you may also not be very happy. But if I get you to be active again, that means you probably are going to wear something else out. And that's just part of being alive. And so none of the surgeries I do come with warranties. I can't tell you that you're going to be healthy forever. I can try to do the best I can to make you feel better and to fix the problem that you have. And so part of what I do when I have patients who have problems is we talk and we try to explain what it is I'm fixing and what that means and what the nature of being fixed means and how long that lasts and what it means to break and what's your responsibility. And part of people's responsibilities is to try to be healthy. Sometimes that means quitting smoking or losing weight or getting stronger. And so it's always a sort of a shared responsibility. I promise to do the best I can to fix what I can. But you also have to do the best you can to be as healthy as you can, which may mean to lose weight and to get stronger and to do things the right way. But even if I do the best I can and you do the best you can, sometimes stuff happens anyway. And that's just how life is. So there are no warranties in this stuff, and there's no one way to fix things forever. Um, if you hear somebody and you see an ad on television that says something is going to fix you in a little cut and fix you immediately and you're going to feel better forever, and if it sounds too good to be true, I can guarantee you it is not true. It is too good to be true. It's simply a lie. Um, there's nothing that's simple and good and easy. It just doesn't work that way in pretty much anything, certainly not in medicine. So if you come here as a patient, you'll be evaluated and you'll be offered a selection of non-operative techniques if those are appropriate for you, or surgical options if you need surgery right away. We try not to string you out, but we do what's most appropriate. For most people, we try to do conservative care first. Surgery should generally be a last option. Um, it's not a fix-all, and we try to get people better with your original equipment if possible. And only if non-operative care fails, then we consider surgery.
You mentioned several tests earlier, and people have probably heard of MRIs and CTs as they're pretty common, but what are nerve conduction studies?
A nerve conduction study is an electrical test done by either a neurologist or physiatrist that tests the electrical activity of the peripheral nerves in your body, usually nerves going down your legs or going down your arms. And it can test for things such as if a nerve is being compressed in the spine or being compressed by other structures, either in your arm or in your legs, or can test if the nerve is being affected by certain disease disorders, such as diabetes or something else that can give rise to something called a neuropathy. So these tests can help us decide if a pain in your leg is, say, coming because it's being pinched by a disc herniation in the back, or is it hurting because you have diabetes and you have what we call peripheral neuropathy from diabetes. And so different things can cause different types of pain, and we obviously don't want to fix something that ain't broke. And so we try to use these tests to differentiate between different things that can cause pain in an arm or a leg, and they help us decide what the best treatments are.
What does conservative care mean?
Conservative care is a generalized term that often means non-operative care or the least invasive care. So it's also can also be considered to be what the most standard care for that treatment is. So conservative care for someone with back pain would often first be exercise and rest at first, but generally exercise and mobilization and strengthening and getting people moving. And the last step or last consideration would be testing and surgical intervention, because we want to try to stay away from surgery. If someone's having a dramatic neurologic injury, say you had a bad problem which was affecting your bowel and bladder function, well, for a standard of care for something that was causing a surgical emergency, the standard of care for that may be surgery. So some people would say conservative care for a surgical emergency is surgery, because that's the standard of care for that. You want to get that taken care of right away. Generally, when you hear someone use the term conservative care, they're talking about non-surgical care for a problem. And the usual hallmarks of conservative care are things like injections, medications, physical therapy, and the like.
Is there any sort of standard timeline for how long conservative care will be tried before surgery is the option?
Well, first of all, it depends upon whether surgery is ever an option. There are only very few diagnoses have surgery as an option. Many patients come into me and they say, well, I want to be fixed. But the sad reality is that only a few problems have a surgical answer. So I would tell you that, first of all, conservative care for most problems is the only option, because there are only a few diagnoses that have a successful surgical answer. So for many people who hurt, there simply isn't a surgical answer. There's not a surgical answer for every problem. But if somebody has what someone would consider a surgical problem, depending upon what that surgical problem is, conservative care can last differing periods of time. We usually try to wait at least until the normal healing time for a problem is. So, for example, if someone has sciatica or pain in their back and leg due to a disc herniation, generally those things get better in a 6 to 12 week period of time with what we call conservative care. 8 out of 10 people get better in 6 to 12 weeks through non operative management. So, conservative care is buying patience. We try to get people to feel comfortable enough to wait out 6 to 12 weeks until they'd otherwise get better on their own. And so that's what conservative care often is. When do we consider surgery? Well, there are two different times when most surgeries happen. There are times when me as a surgeon say you have to have surgery, and then there are times when a patient comes to me and says, Doc, I'm fed up. I've run out of patients. You have to fix me. Those are two different indications for surgery. For a surgeon, someone has surgery when they're having a progressive neurologic deficit. In other words, they're weak and getting weaker or numb and getting number, and we're afraid that their nerves or their nervous system is being damaged by further waiting. And then that's the time I'll go to the patient and I'll say, you may wish to wait, but it's not smart to wait any longer. We need to proceed with surgery. And that's when conservative care, I would recommend to them that conservative care ends. For a patient, conservative care often will end when they'll come to me and they say, Doctor, I know you've given me medications and therapy and all the other aspects of conservative care, but I can't wait any longer. And that's a more difficult situation. That's when they've run out of patience. And they may have run out of patience because they are in a lot of pain, or they may have to get back to work, or various other issues in their life may be forcing a decision that they feel like they have to consider a surgery now. And that's a discussion that I'll have to have with a patient and try to talk to them and see if surgery is reasonable for them and if they have a diagnosis where surgery is actually a reasonable answer. For example, it's not uncommon. I'll have a patient who, say, does heavy manual labor, and they're hoping that a surgery will allow them to go back to that heavy manual labor. But I'll know that surgery is not going to really bring them that relief that they're looking for. That maybe it's because of age or the extent of surgery that even if I operate on them, it's not going to allow them to lift as much as they think they need to lift and to work the type of work they're going to need to work to get back to the job that they've had. And so that sometimes takes a difficult discussion where I'll have to talk to a patient and say that they may have to, that surgery may not be the right answer, that they may have to actually consider a different line of work or do something else, because I don't have a surgery that can give them the answer that they're looking for. I don't have a surgery that can make someone who's 65, 25. And that often is what happens, that I'll have somebody who is in a very difficult situation where their back hurts and they're in the later part of their working life and they've been working a heavy manual job for 30 years and they simply can't do the same type of work that they were doing when they're 25 and now they're 55. And that's a hard discussion to have because what they want to do is be fixed so they can do the 25-year-old job. And they just simply can't, and there's no surgery that I can do for them that makes them 25 again. And that's a hard problem. And so we try to explain this to them, but that's a hard discussion to have.
How much back pain should I experience before I make an appointment with an orthopedic physician?
I mean, most people's pain resolves in a short period of time, whether it be a few days or a few weeks. And everyone experiences pain differently. Even in my own family, I have family members who have some pain and they're on the couch and are immobile, and other people seemingly could break their arm and don't bother mentioning it to anyone. And so everyone's pain tolerance is entirely different. And so it's hard to say how much pain is too much pain and how much should you tolerate. This is a personal decision that everyone has to make in terms of when they go see a a caregiver to have something evaluated. As you grow up and you learn what hurts and what doesn't, you have to develop a sense on your own of what pain is unusual and what pain isn't unusual. Certainly, if you experience weakness, numbness, if you're experiencing weight loss, change in your bowel or bladder function, these are all red flag symptoms that should lead you to go see a physician. Um, just having back pain in and of itself that's atraumatic for a short period of time, whether that's hours or days, is not in and of itself a particular concern. Most people's back pain gets better. But if it seems to you to be overly persistent and overly bad, I would go see your family doctor and have it evaluated. Whether you should see a surgeon for it is another level of intervention that, quite honestly, in this country, we tend to see surgeons much faster than any other country in the world. And we probably see them sooner, which is why more people in this country get surgery than any other country in the world. So I think we rush to see surgeons a little fast, which is why in this practice we try to keep people out of my hands and try to have people treated conservatively as best possible. But if you're concerned, there's no harm in calling us, and we're happy to evaluate you. Many people find that they get better, very quickly, and most back pain, again, gets better on its own in a matter of a couple of weeks with just, return to normal activity in time. And so I would caution people or reassure people that most people's back pain is not a serious consequence and gets better. But if you have concerns, certainly talk to your family doctor or make an appointment and see one of us. And, we will evaluate you and try to give you good hints on how to get better. And if we see something of concern, we'll get further testing and move on from there.
If you and the patient have decided together that this patient should have surgery, what are the next steps?
Well, it very much depends upon the scale of the surgery and the area of the surgery. Often depending on the patient's age and medical history, the discussion also leads us to involve the patient's family doctor in evaluating their overall health and making sure that they're healthy enough to undergo such a surgery. If they have cardiac disease or other medical problems, we have to involve their other medical doctors, whether it's cardiologists or pulmonologists involved in that decision. It discusses scheduling it and getting their health maximized before the surgery. We discuss all the needs that they have after surgery and what their expectations are so that they're prepared, and they and their family are prepared to deal with all the issues that they have after surgery, so that it's a smooth transition before and after surgery, so they can have their house situated and their family situated in such a way so there are no shocks or surprises. Most patients go home. I would say 90% of our surgeries, patients go home the day of or the day after surgery. And so we need patients' families and prepared for what their needs are after surgery and to make everything smooth and calm. We want them to have a smooth and active recovery. So we have all those issues prepared for them, and we give them information so they know what to expect. But so those are the discussions involved. But most of our surgeries are very focused on a specific pain, and we try to get them relieved of that pain. And quite honestly, very often once the patient's main pain is relieved, the recovery is spontaneous and fast and not terribly complicated. So that's not much of an issue.
Last question. You mentioned that you will fix issues from previous back surgeries. Can you speak a little bit about that?
Well, very often patients may have had previous surgeries and that have been successful, but then have developed further problems. Like I mentioned before, people continue to get older and wear things out. Just because you've had the problem fixed once doesn't mean you're not going to have another problem. And those issues, when you've had surgery once, can be more complicated. Some patients may have had surgeries that did not give them the results they were hoping for from a previous surgery. And they wish to be reevaluated to see if they're something that could be fixed that needs further evaluation, and whether there's ongoing pathology that needs to be addressed, or some issue that's outstanding. And those are complicated problems. So it's not uncommon that I'll see patients who've had previous surgery that have had continuing pain or new pains after surgeries that are looking for further guidance as to what they can do to help them with what their symptoms are at that point. And so we see them and we evaluate them with various diagnostic studies and try to see what the source of their pains are. And sometimes that's trying to get a reevaluation of what their pain was to begin with and seeing what their pain is now to see if the goals of the initial surgery were successful and trying to come up with a new treatment plan for them at this point. And that's a complicated matter to try to rethink things. And there are a number of patients in our community that have had surgeries that are hurting and need assistance in trying to figure out what direction to go with their medical care at this point. So we do what we can to try to give them guidance and with how to address their ongoing symptomatology. Sometimes it's what we call salvage procedures or ways to manage their pain and to help them get through the day. Sometimes they could be major surgeries. Sometimes very often it's just trying to explain to them where their pain is coming from and reassuring them about what's going on, and they just need someone to talk to understand what's going on in their back because maybe it's never been fully explained to them. And so both from information and discussion and reevaluation, patients get solace from just having their cases reviewed. And so it serves multiple purposes, but it's one of the things I do not uncommonly.
Thank you, Dr. Kerner. Anything else to add?
We're happy to help you, and but we try to be very realistic with our patients and try not to exaggerate what our capacities are. And so it's our practice focuses on tried methods that are scientifically based, and we're happy to help people who are interested in having their situations managed. Thank you very much, and happy to see you down the road.